Next, Bernard Gersh and Dr. Borge Nordestgaard, physician-in-chief and professor of medicine at the Copenhagen University Hospital, discuss CCHS, genetically reduced non-fasting triglycerides and reduced all-cause mortality.
I guess we can begin by saying that as we think of hyperlipidemia, at least as a clinical cardiologist, which is what I am, we talk a lot about LDL cholesterol for all the obvious reasons from the trials. Tremendous amount of interest in HDL cholesterol, both epidemiologically and in terms of artificially elevating it with drugs. And perhaps the sort of forgotten component of hyperlipidemia are the triglycerides.
Fully agree. And I think to be more specific, it's actually the cholesterol content in the triglyceride-rich lipoproteins. I call it remnant cholesterol. But if you have total cholesterol in plasma, there's three fractions, HDL, LDL, and the rest, which is what is in the triglyceride-rich lipoproteins, remnant cholesterol.
So give us the actual background to your study. I know you have these magnificent databases throughout Denmark. Which particular database did you use?
So in this study is a very old one. It's called the Copenhagen City Heart Study. It was started in 1976-78, and it was actually mimicked to be done like the Framingham Heart Study. So we ask all the same questions. And then we studied these individuals.
Just as a matter of interest, it has been said that the Framingham Heart Study probably gave the National Institute of Health in the country the biggest return on its investment of any study. Dr. Braunwald actually said that. And I think it's given the world a huge return on its investment because it identified in the 60s the risk factors.
Yeah.
And in your study, you've asked the same questions, and I know this is not relevant to your particular project you're talking about today, but you've also received the same answers, haven't you?
Yeah, for these type of things we have, but of course now we ask different questions where I think one thing that's different from our type of study in Denmark is that we can recruit from the general population. We invite people at random. So in this particular study in the 70s, there was actually, I think, 75% of those invited turned up. So it's really representative. And then we can follow everybody. And in this case now we looked at total mortality of these 15,000 individuals. 10,000 of them have died by now during more than 30 years of follow-up.
But one of the great benefits of the Copenhagen study, in terms of going back to the Framingham study, is, what we've learned, and we've also learned this from Salim Yusuf's studies, basically the traditional risk factors apply everywhere. There may be novel risk factors in the developing world, but the traditional risk factors behave in most countries of the world in the same way.
Well, I agree.
But let's go back to your specific study. 15,000 patients.
Individuals, they're not patients. It's like you and I. They're from the general population.
I beg your pardon.
I know you're a physician, but it is ordinary people.
Yes.
We measured triglycerides way back, and we followed them for 30 years, and we know exactly who died and who didn't. Yep. There's 100% complete follow-up. The reason why I wanted to do this study is because there's too little focus on high triglycerides or cholesterol in those. All the focus is on LDL. But I think there's a lot of residual risk here. So we looked at those that lifelong have lower triglyceride levels. Do they have less risk of dying early? And this was really, really strong. So observationally, if we looked at, compared with those that had levels of 3 to 5 millimoles per liter, which is like 270 to 440 milligrams per deciliter,
right,
and compared them with the ones that have very low levels, less than 1 millimoles per liter or less than 90 milligrams per deciliter, then the ones with the lowest levels, they only have a hazard ratio of dying that was 0.5 compared to ones with 4 to 5. And that's over 30 years. So that's very impressive.
Huge. And that is adjusted for?
Whatever you can adjust for.
HDL,
Not HDL, because HDL, we actually didn't measure HDL, but HDL and triglycerides are inversely. So if you have high triglycerides, you have low HDL and vice versa.
But it's adjusted for LDL, total cholesterol.
Yeah, whatever you want to.
All the other risk
physical
factors.
Activity and, all these sort of things. Yeah, diabetes and so forth. Anyway, the thing that we did here, because this is observational, but we did it genetically also. So we genotyped people for 4 variants in the lipoprotein lipase, which is the most important enzyme degrading triglycerides. And the ones that genetically lifelong had low triglyceride levels. And using these 4 different genetic variants, we could compare some that lifelong had a 31% lower triglyceride levels. And they had a hazard ratio of early death of about 0.7. So both in observational epidemiology and in genetic, we can see that lifelong low triglyceride is causally associated with you live longer.
That's fascinating. With all the interest in the lifelong low LDL levels and the PCSK9 inhibitors, you're actually showing the same pattern with triglycerides.
Exactly the same. And nobody has done that before. Nobody has a study with so much power for all-cause mortality. I'm not aware of any study that has so much follow-up for all-cause mortality.
Extraordinary.
I mean, the hope for a study like that is that this will generate more interest in actually recruiting patients to triglyceride-lowering therapy and looking at all-cause mortality. Just a study like the 4S trial that showed us for the first time when you lower LDL, you reduce all-cause mortality using statins. But we need a trial like that with people with high triglycerides. That's what I hope for.
And as a matter of interest, what drugs would you use if you're going to do that trial?
The best bet would actually be to do the potent statins. Most statin trials so far has excluded those with high triglycerides and focused on those with high LDL. So you simply wanted to take a trial where you include people with triglycerides probably above something like 2 millimoles per liter or maybe 3 millimoles per liter, which is corresponding to above 180 milligram per deciliter or above 270 milligram per deciliter, and just do a statin trial, but in those with high triglycerides. Of course, there's many other drugs coming about now, but statin is the obvious one because the most potent ones like atorvastatin or rosuvastatin, they're quite efficient at reducing not only LDL but also triglyceride.
So really what you'd want to do is get a group of people, maybe difficult to recruit, but people with, quote, normal or low normal LDL levels and high triglycerides.
Yeah, something like there's lots of those.
Are there?
All the obese and overweight, that's the lipid profile they have. So you can find there's lots of those out there. You could use fish oil also, but I think statin is more likely to be more efficient.
Yeah, I mean, the fish oil data is all over the place.
Yeah, I agree.
I'm not quite sure about it.
Yeah.
And particularly, I mean, in Denmark, I mean, you've got a fish-eating population anyway. But just one other technical sort of issue. How in a follow-up, and I'm personally always very interested in natural history studies, and I know your database well from the atrial fibrillation world where there's some very good studies. How do you adjust for the fact that during the course of the follow-up, those patients may develop diabetes or may develop hypertension? Do you have a continuous form of risk adjustment or multivariate analysis? Because I know at baseline they don't, and you adjust for that, but over the course of a 30-year period?
I mean, this particular study, the Copenhagen City Heart Study, we examine people every 5 or 10 years. And so we have repeated measurements of risk factors. So if they change from being a non-diabetic to a diabetic, then we'll change the covariates and take that into account.
So leave us with a take-home message.
Elevated triglycerides is a cause of dying early on. And what we show particularly here is that if you lifelong live with lower triglycerides, this is causally associated with that you simply live longer. So I think this is a very good starting point for making a randomized intervention trial to show that you can do that using drugs.
I congratulate you on a very fine study and thank you for sharing it with our ACCEL audience.
Thanks very much.